Hello, everyone. Good afternoon to those of you who are in North America, and welcome to all of the attendants from other continents as well. I'd like to thank all of our panelists for graciously agreeing to participate in this very important discussion. I'm Dr. Charles Dubrovner. I'm clinical professor of OBGYN at NYU Langone Medical Center and past president of the New York Society for Ethical Culture and the Humanist Institute. I'm currently a medical coordinator at the New York State Health Department, Office of Professional Medical Conduct. I was the co-founder of Global Bioethics Initiative, together with Annalita, PhD, who is the executive director. GBI is a nonprofit educational organization dedicated to fostering public awareness and understanding of health and bioethical issues, and to explore solutions to bioethical challenges. I am also 85 years old, so please forgive me for relying on my notes during this presentation. So without further ado, let's dive into our topic today: COVID-19 vaccines, hype or reason to hope. COVID-19 has caused a dramatic loss of human life worldwide and has devastated the economies of many countries. Several vaccines showing promising results in preventing COVID-19 have been approved under emergency use authorization. This webinar will discuss the main challenges faced in ensuring that vaccines will be important in the fight against COVID-19. Let's first meet our two speakers. Dr. Art Caplan is the Drs. William F. and Virginia Connolly Mitty Professor and founding head of the Division of Medical Ethics at the NYU Grossman School of Medicine in New York City. Prior to coming to NYU, Dr. Caplan was the Sidney D. Caplan Professor of Bioethics at the University of Pennsylvania Perelman School of Medicine in Philadelphia, where he created the Center for Bioethics and the Department of Medical Ethics. He received his PhD from Columbia University. He's the author and editor of 35 books and over 725 papers in peer-reviewed journals. His most recent books are The Ethics of Sport with Brendan Parent, published by Oxford University Press in 2016, and Vaccination Ethics and Policy with Jason Schwartz, published by the MIT Press in 2017. He's also a member of GBI's advisory board and helped greatly with the launch of the organization in 2013. Over the years, he's been one of our most important advisors, and I thank him again for being here. Brendan Parent is an assistant professor in the Division of Medical Ethics at the NYU Grossman School of Medicine, and he is also the director of the Transplant Ethics and Policy Research area. He's also the director of NYU Sports and Society. He serves as chair of the Ethical Issues in Healthcare Committee of the Health Law Section of the New York State Bar Association and as editor of its Health Law Journal. He's published academic articles in peer-reviewed journals spanning law, medicine, science, sports, and ethics. And his work has been featured in the Washington Post, Chicago Tribune, and on NPR. He received his undergraduate degree in bioethics at the University of California, Santa Cruz, and his JD from Georgetown University Law Center, where he was presented with an ABA award for excellence in health law. He focuses his main interest now on healthcare, ethics, and law. He contributed to the New York State Pandemic Resource Allocation Guidelines and consults with global companies on vaccine distribution and liability waiver for COVID-19 infection, to return to sport, and hospital resources triage. Let me now turn the program over to Karen Weintraub, a noted journalist who will, if she's not too modest, will tell us a little bit about herself before she continues the program. Karen?
Hi, thanks so much. So I'm Karen Weintraub. I've been covering COVID and vaccine development for USA Today. and have spoken to Art a number of times during this process and on many other topics before that. So always appreciate your perspective. Why don't we get right into it? Brendan, I think you're going to start with a short.
Karen?
Yes.
Well, one person on the in our audience asked if we had any disclosures to make, and so I will say I have done conversations with Janssen and Moderna on their vaccines, but not paid. Just they call up, ask for advice. I give them advice. I'm on the NCAA and U.S. Mayors Conference committees on sports and COVID, and I serve on the WHO Early Access to Drugs and Vaccines Committee and the Lancet Commission on COVID. But I don't really have any paid conflicts other than we have been doing some work with something called the Midyar Group and Accenture, where they've asked us to give them advice for money about COVID policy. But they're not pharma or vaccine companies. Midyar is actually a foundation.
Great, thanks.
And if it's my turn to do some disclosures, I'll say the same in terms of working with Art on Midyar and Accenture projects. I've also been doing some advising with state representatives for New York, California, Rhode Island, and I can't think of anything else that might qualify as a disclosure, but if I think of more, I'll be sure to do so over the course of the talk.
Great. Do you want to start?
Sure. So if it's time to launch into it, thank you all for being here, and happy almost not 2020. I say that with a major caveat that even when it is no longer 2020, things are not going to be perfect. I'm sorry to be that person, but it's important. There is light, right? And the light is we have about 200 vaccines in development currently. And there are 4 different types. There's whole virus, protein subunit, nucleic acid, viral vector, and they all use either some version of the virus or a different virus or pieces of virus or DNA or RNA to trigger an immune response in the body. And of these 200 vaccines, about 18 are in the final stage of development, phase 3 trials. But we haven't even been developing them so long as to reach the end of phase 4. The whole process from the start of these trials to now has been, 10 months, which is extraordinary because most vaccines take a decade or so to reach the public. So this really is an amazing feat. We have to give credit where credit is due. They didn't start from scratch. A lot of research on Ebola and previous SARS virus helped create the foundation for where we are now. Of the 18 vaccines in final stages, 2 have technically hit the shelves, right? Pfizer, BioNTech, and Moderna, we've heard about them in the United States. There's an emergency use authorization. And for Pfizer, in other countries, including the UK, Canada, and a couple others, there is full approval, so the pressure is on. For the 2 frontrunners, they have demonstrated to this point approximately 95% effective rates in terms of preventing symptoms in individuals. So this is great, right? But now everyone in the world needs one, but we don't have enough yet. So how do we distribute them? There are 2 sort of competing principles that guide allocation. On one side, we have cosmopolitan considerations, which is the notion that everyone has a duty to take care of everyone else. Juxtapose that with nationalist principles, which is that it is your duty to take care of your own. If you are the government, you take care of your country. If you are a company, you take care of your employees. So in theory, if everyone does this, then everyone gets cared for, right? But the problem is that not everyone has equal resources or power to take care of their own. So in order to be good humans, we need to care about more than just our own. So how do we combine these principles effectively? There have been a number of frameworks proposed for how to distribute the vaccines globally in a just way. And these include doing it proportionate to the country's number of healthcare workers, or proportionate to the population that is over 65, or the proportion of the population that suffers the disease burden. All kinds of proposals have been put out long before the vaccines were actually on the ground. But in the shortest term, the actual distribution has been driven by who has purchased from the vaccine companies. In early 2021, we will have this other effort. The Global Vaccine Alliance has a program called COVAX that will start a serious attempt at equitable distribution. COVAX has 190 countries invested in this communal project with an advanced market commitment to 92 low and middle income countries, so that the most vulnerable people in those countries will get vaccinated in the first 2 quarters of 2021. This includes 2 billion doses across several vaccines, hoping for an approximate 20% vaccination rate in those countries. Now, there's some caveats, concerns, technical hurdles, obviously, that this project, the COVAX project, relies on at least 9 vaccine candidates for which we don't have the data yet. And the scheme might leave some low-income countries without a vaccine until 2024. And the USA is not on board. If they came on board, this could help vastly change the power to effectively, globally, cosmopolitanly distribute the vaccine. So we still have this global effort, but nationalism is currently winning out. I do believe these can be reconciled as long as there is a limit to nationalism. You have to take care of your own, but only as much as you need, right? And then share. So the analogy is, as an individual, you don't need to give up all your personal wealth and go join a monastery. You just need to give what you can afford. So guess who the greediest nation is? And I say this lovingly, Canada. Canada has about 9 doses per person, right? They ostensibly, once all their population or enough of the population is vaccinated, should give some away. And they are already in talks to do so, giving away vaccine to countries that need it but don't have the resources. So how do we distribute at the national level? I'm trying to kind of go down the funnel here. In the United States, we have 328 million people, and there have been several frameworks proposed for how to distribute within a country, whether it's according to your degree of risk, your vulnerability in terms of comorbidities, how sick you are you a healthcare worker, are you older adults in congregated settings? There are many ways that this could be done, and many of these ways could be equally fair in principle. So it might be less about the specific hierarchy, who goes first in line, and more about agreeing to the process. If we all agree that it's going to be done in a certain way, then it should be fair. And in the United States, we have some agreement that the very first people we see being vaccinated right now are healthcare workers and people in long-term care facilities. That said, it's still a bit of a mess, right? There are different ways to define healthcare worker and long-term care resident or worker. In Kentucky, 2/3 of the vaccine are going to long-term care centers and 1/3 are going to healthcare workers in COVID-19 units. In Indiana, hospital chaplains are included in the very first group. That's not true everywhere. In Tennessee, healthcare workers who are 65 and older are getting the absolute first batch. So it's all over the map, and a lot of things are going wrong. Technical distribution errors include the fact that original estimates for how much vaccine each country was going to get were not certified by quality control. And so there is a difference between the amount states were promised and the amount they're actually getting. The head of the Operation Warp Speed recently apologized for a shortfall to 14 states, some states getting up to 40% less than they were promised. In one leading hospital system, an algorithm was used to decide who was going to get the vaccine first of their healthcare workers, and that algorithm left out all of the medical residents, i.e. the people who are on the ground treating COVID-19 patients. There are a number of extra doses being found in the bottom of vials, and the people who are administering the vaccine don't know what to do with this. So before FDA came out with guidance saying, yes, you can use the extra dose if there's enough, people were just discarding that. And That's obviously a precious resource problem. Then we have issues of hesitancy. There are recent surveys that suggest about 1/3 of nurses are not sure whether they want to take it. Another third are completely unwilling to take it, citing fears about allergic reactions, the fact that FDA and CDC are too political and not trustworthy, that the clinical trials have been shortened, there's not enough data collected. And then we have a very critical fact, which is that the populations who have been hit hardest by COVID-19, i.e. Black, Indigenous, people of color, Latinx, are also understandably hesitant to take the vaccine for the same reasons. The systemic racism and inequities in access to healthcare, nutrition, education, and distrust of the medical system due to historic and ongoing medical abuses of minority patients. So we have a problem here, right? How do we get the buy-in? How do we ensure that this is actually safe and effective? After healthcare workers and long-term care residents, a panel of the CDC recommends the next in line should be those who are 75 and older, then the frontline essential workers. Well, how do we define essential? That is still going to be left up to each individual state. How should we define it? Is it that society would collapse without you going to your job? Or that we just really, really like being able to get our clothing dry cleaned? Or that people would die? Or do we perform the legal maneuver of avoiding definition of essential altogether and just say, well, if most people agree this is essential, then it should be essential. So what about postal workers? Yes. Meat factory workers? What about the World Wrestling Entertainment industry, which during the initial surge, Florida dubbed essential for purposes of staying open? I'm not going to define now, but I would argue that essential services should be mediated to some degree by how easy and effective it is to do work remotely. So for example, teaching second grade, not easy. Giving legal or ethics advice, very easy. I will gladly take my place at the end of the line. There are a number of those in the gig economy who are trying to get their employees or contract workers to be deemed essential. Uber, Instacart, wrote to the governor of New York to say our employees should be essential. Other groups, Hotel Trades Council, groups for superintendents and building maintenance. Then we have celebrities, right, who are either jumping the line or arguing that they should. Are they essential, or are they influential in ways that will get buy-in from communities? There are a lot of categories, and we will easily overrun supply in the near term. I have a fear, and my fear is that people who know physicians can ply their friends who are physicians and say, hey, you diagnose me with something, maybe you can get me up in the line, I can get a vaccine sooner rather than later, right? Well, one vaccine for a healthy person who doesn't need it at this moment is one less for someone at greater risk. On top of that, we have the possible shortfalls in production, not enough glass, not enough dry ice. So what should you do? I said at the beginning, nationalism, even at the company or family level, is only ethical if there are limits. I don't blame you or me for wanting access to the vaccine ASAP, but many of us don't need it yet the way our 65 and older, 75 and older, friends with various conditions that make them more susceptible to illness, essential workers, healthcare workers need them. Masks and social distancing are annoying and awful, but they work and they cannot go away. We all have vulnerable people in our lives. So if you have one, advocate for them. At least in the United States, government is not going to be able to knock on every essential worker or vulnerable person door and say, here's your vaccine. So check your state's distribution plan, find out where and how distribution is happening when we get to that level, and help those who are called up when it's their time. So with that, I'll stop and pass it back to Karen and or Art.
Art, you want to pick up from there?
Sure. So there are a lot of other interesting vaccine issues to add to those that Brendan presented to you. I'm going to start by talking a little bit about vaccine nationalism as well. My colleague Kyle Ferguson and I at NYU wrote a paper recently for the Journal of Medical Ethics, which was about a kind of defense of a form of vaccine nationalism. Vaccine nationalism has gotten sort of a bad reputation. It basically has been attacked by many, many writers as selfishness, meaning the rich Western countries or the US buys up all the vaccine supply, leaving the rest of the world at risk and unvaccinated and with no access. And some who've argued for expanding the COVAX program and other international efforts to get more money for vaccines have been particularly critical of the idea that just the rich countries, US, Britain, Canada, as Brendan pointed out, Germany, Belgium, UAE, Saudi Arabia, many others have been buying both the Pfizer and the Moderna vaccines, AstraZeneca's not yet released vaccine, and Chinese vaccines. But I want to argue, and we argue, that a version of vaccine nationalism makes sense. And I think it does. I think there is some duty to recognize that everybody in the world has moral standing, and we have to worry about helping them and allowing them to flourish. But at the same time, I think it's also true that we are right or justified in taking care of our own family, our own community, our own town, our own nation first, before we get on to the needs of others. So the neediest groups in the US, whether they're nursing home or healthcare workers or maybe essential workers, I do think that it is correct to say we ought to try and attend to their needs first, not treat them as equivalent as somebody in a foreign land. If you will, we have obligations, special relationships to certain parties. And once we take care of the at-risk group and the groups that are most in need here, then we should look at the groups in other countries with equivalent priority. I don't think we should vaccinate the entire United States before we move on to worrying about other countries that are having problems like a Peru or a Mexico. But I do think taking care of our high-risk people, prisoners, intellectually disabled in institutions, psychiatric facilities, some definition of essential workers does make sense. It isn't ethically wrong to say I'm going to try and start there, get stability here in my country, and then move on to try and aid others. Second point I want to get into is mandates. A lot of people are asking, when would we mandate a vaccine? When would a vaccine be required? Well, no one's going to be requiring, and I know Brendan agrees with me on this, a vaccine that is only available under emergency use. That is, it is partial data, incomplete data, data that looks good, but the situation, say an out of control plague, is so bad that you're going to permit utilization of the vaccine even though you don't have the full picture. In emergency use, the data on both of the Moderna and Pfizer vaccines has looked good. It's been vetted by an independent data safety and monitoring committee. It's been vetted by the advisory panels to the FDA and the FDA itself. And I believe, I mean, I'll trust the science there, that it wasn't politicized or manipulated by the administration or the White House or somebody to cut corners. I mean, I think the data looks impressive. Most independent scientists that I've talked to have also felt, wow, 90–95% efficacy, no big safety events, other than a tiny number of vaccination adverse events reported. It's amazingly good. So that's great. But it's also incomplete. We don't know how long the vaccine's protective power will last, duration, 6 months, a year, 2 years, it'll stop in 4 months. We don't know. There's no data on that because we haven't studied the recipients out that far. We don't know whether and how effective the vaccines are against stopping infectivity, the spread of virus. You could get a vaccine and not be at risk of getting very sick, but you still could shed virus and infect others. I hope not, but we don't know that. And there could be long-term adverse events that didn't pop up until a year or two out post-vaccination. That's rare for most vaccines, but again, we don't know that. You're not going to be able to mandate that somebody take a vaccine if you have all that unknown and incomplete information. So talking about mandates right now outside of the military, which seems to mandate everything for everybody that's in there, then I'm sure they're having to take vaccines with no ability to refuse, and they'll get court-martialed if they tried to say no. But outside of that group, I don't think mandates are coming. What would take to mandate is licensure. You'd have to have enough data for the FDA, not just to say it's okay on emergency use. You have to have enough data to say it's okay to sell it. It's approved as a commercial product. I don't expect that we'd get that data normally in a vaccine for 6 months, maybe as long as a year, and you'd have to run a randomized placebo-controlled trial to prove durability, to prove safety all the way out, let's say, for a year. The problem is when you have emergency use authorization, I don't think we're ever going to get that data, because the people that are in those studies right now, they're thinking, hey, you just approved it for emergency use, particularly if they're in a risk group, if they're older, or they have comorbidities, or they're a healthcare worker, some of whom are people who signed up to be in the Pfizer or the Moderna trials, or the AstraZeneca trials for that matter. They're going to say, you know what, I'm dropping out. I want to know if I'm in the placebo group, because I'd like to go get that vaccine because I'm in an at-risk group and I don't want to be in this study anymore. And there's been some discussion, even among FDA officials, of not unblinding these trials and of saying we need to get the longer term data done so we can license the vaccines. And I just think that's ethically never going to happen. You have to unblind the studies. You have to give the subjects the right to stay in or drop out as they wish. You don't necessarily have to say because you're in a study, you get first dibs on the vaccine. Some people have said that, but I don't think that was in the consent. But you do have to say we can unblind you. And if you are in a high priority group, then go ask for the vaccine and go get it. So I think those studies are going to fall apart, and we're not going to have the usual data that we would get in order to license a vaccine. Plus, parenthetically, for new vaccines coming along that are just starting, I don't think people are going to sign up for those studies in the same way. If you have 2 emergency use vaccines and then another one comes out and gets approved for emergency use, say AstraZeneca's or Janssen has one that's kind of further along, they say they're going to be submitting for approval for a one-shot vaccine without heavy refrigeration by February, early February, I've seen. Then a lot of people are just going to say, well, to hell with it. I'm going to go get those vaccines. And there seems to be easier access to them, both in the US and in other countries, because now there's a lot more vaccine supply, and I'm not going to be in a placebo trial. So I think ethically we have an issue coming up. We can't mandate those vaccines. You're going to have a right to refuse them. No one's going to be able to force you to get one. But we also may have to use incomplete data to license them. We'll have to try and follow people who got vaccinated and see whether the durability seems good and the safety seems good. But again, they're not in a placebo-controlled trial, so it's harder to get reliable information. You don't know if the infection rate was lower in the vaccinated group than it was in the unvaccinated group because they're not randomized. It's just going to be what sometimes is called real-world evidence, which is less secure and less reliable when it isn't randomized, and there's no way that the follow-ups are going to be randomized. I should also say, just grimly, we've never had much success at following drugs or vaccines post-approval. That in that part of the world, what's called the phase 4 study has just been terrible. CDC says it's set up a national registry to follow some people who've gotten vaccinated and see what happens to them. We'll see. It's not the biggest budgeted program I've ever come across. And getting people to doctors and others to report what's going on as people wander around out in the world 6 months out or a year out, I don't know. We'll see. I hope we take it seriously and do it because it's the best chance we have to know what the hell's going on with these vaccines. But it's going to not be the same picture we normally would get with an approved vaccine. On the other hand, if you then say, well, 6 months out, data's messy, but we're going to approve it and license it because it looks like it's good enough, then I think you'll start to see mandates. And I think we'll see them in a couple of ways, and then I'll shut up. one mandate is likely to be in healthcare systems. I pushed over the years for mandates for flu vaccines. Flu vaccines don't even work that well, but they're low risk. And so in some years, they really do help prevent ordinary people from getting the flu. So it seems worthwhile to require them so that the workforce doesn't get sick and they don't infect the patients or each other. That, as I said, efficacy is up and down depending on the year and the strain, but we've got mandates in almost every hospital system. In pediatric children's hospital in New York has a law requiring mandate vaccines or masking. And I think we'll see that in health systems for COVID vaccines. I think people will just say you can't work here unless you get vaccinated, and they're not going to take any objections except health objections to non-vaccination. And even if they take a health objection, I think you're going to have to mask or not work in high patient exposure areas. Then I think we'll see the private sector start to push some mandates for it. If I ran a cruise line, or if I ran a hotel in the Caribbean, or if I was an airline CEO, I'd want a mandate just to get people moving. Amtrak, another likely place. So some of those places may mandate just because they've had bad outbreaks and people are scared to go there. I guess you could even imagine a Broadway show saying, hey, we're back. And it's true, you're sitting on top of one another and maybe you're still going to have to mask in here and our ventilation stinks, but everybody in here has been vaccinated. So maybe an industry like that might try to mandate. I'm not looking for government mandates first, but then some employers may also say, you want to come back to work? We're going to have masking, we're going to have some social distancing, but we expect you to get vaccinated. You're going to go out and see clients. We have to be sure that they trust that you're safe and you're not going to infect them. So we may see different types of workforces push forward mandates, and those will get some protests and we'll have some legal fights about whether that can happen. And I think companies can do it as long as they can show that they're not discriminating against anybody, in that it is essential to the operation of their business, a cruise line, that they try to be as safe as possible. So I'll stop there, and maybe we've got some questions coming up, or Karen may have things she wants to ask us about.
I always have questions, but thank you both for that. Why don't we go to a question from the audience first, and if anybody does have a question in the Q&A, you're welcome to post it. I'm also checking the chat. So the first question is to all the panelists, both panelists. Could you give your opinion regarding the UK coronavirus variant? What do you think, and how should we be dealing with this?
I just wrote a little thing for the Hastings Center blog in which I said, yeah, I thought it was a little bit panic. I called it mutation freakout, I think, or something like that. There's something going on. Viruses mutate. We do know that. And that just happens. It's a strategy over evolutionary time that they've used to make sure they can survive against hosts whose immune systems kill them. So there's been reinforcement of subtle DNA changes being passed along. But most mutations are not virulent, and most mutations are not involved with huge bursts of transmission increase. Some are, most aren't. I'd like to see more evidence before I go crazy and say we've got a 70% increase in transmissibility, which would be pretty big, even over any baseline. And at the same time, that number came out of a paper that my co-author, Matt McCarthy, and I looked up, which was a modeling thing that wasn't really based on much evidence about this mutation. So prudent watchfulness. If I were in charge, we wouldn't be having flights coming into the US from Britain. Would have stopped that a week or so ago. They still haven't stopped them now, but that's just being prudent. But I'm not ready personally to go crazy and say, oh my God, we've got a super contagious strain now of the COVID virus. And most of the manufacturers of vaccines have said they think their vaccines are strong enough, broadband enough to take on any mutations.
One thing I'll add to that is, ironically, the euphoria that is springing up around the arrival of vaccines might cause people to get a little bit lax in all of the things that we are tired of: social distancing, mask wearing, etc. So regardless of the data and whether this is a super version or not, if it scares people into following protocol, then I think that could be a positive.
Good point. Somebody else would like you to take us to 2024. We're preparing for yet another election. And assuming most people have received a vaccine by then, what do you see as the ethical fallout from the pandemic?
I'll let Brendan, I'll answer it. I'll let Brendan go first.
I just want to say that how dare you take us to 2024? This is, yeah, anyway. Ethical fallout. Art, you start if you have thoughts.
Well, I mean, a couple of things I think will still be festering. Damage to the economy, still coming out of it, be an election issue. Which party did enough with a stimulus or not a stimulus to help us recover? I think that will be a challenge. I think 2024, we're likely to have a debate about whether in facing future public health challenges or national security challenges, we should be isolationist or we need to be attentive to the rest of the world because threats can come in here, versus the inclination to say, we don't care about the rest of the world, that we saw in some of the Steve Bannon style foreign policy that Trump advocated for and Republicans have advocated for historically, a little more isolationist. And the other thing I think we may see is a shift of congressional power, meaning people do seem to have moved out of the cities a bit. Maybe they won't seem as attractive, I don't know, but there are people moving to the West and the Southwest, and it had change this year, right? Arizona and Colorado have become blue, Nevada, maybe that New Mexico, maybe some of that continues in terms of where people are moving to. Georgia, I think, got a little bluer because it went high tech. Even people talk about Texas being bluer in 2024 as the tech industry goes there. But that's about as far as I would go. I mean, I'm sure there'll be many more things to say, but that's about as crystal ball-y as I can get.
I'm also, this is perhaps not an ethics prediction, but beyond 2024, the next decade, 2 decades, the transformation of interaction, right? As little as we like being stuck in our Zoom boxes and miss personal interaction, I think the fact that a number of businesses and operations can continue remotely means they will into the future. And so what will that mean for actual physical landscapes? I'm hopeful that eventually, real estate might change, like in major urban areas like New York. Maybe we'll see more space actually freed up for people convening outside if, there's a 30% reduction in gyms, in retail stores, etc. That's just the optimist in me, hoping for a transformation of the landscape.
Great. Another question, we could go on this for a while, but another question is the fact that not knowing the long-term effects of the emergency use vaccines puts our frontline workers and elderly population at risk. How do we weigh the concerns about eradicating this virus with the possible long-term ramifications?
Well, even on a bad day, vaccines haven't proven to be that risky long-term. I mean, there have been some rotavirus that had intussusception, an intestinal problem that many years ago held that vaccine up. Dengue fever and the vaccine for that caused a big problem in vaccination of children in the Philippines with deaths. Even the polio campaign to try and eradicate it is causing polio probably at a higher rate than it is preventing it at this point. I mean, using the vaccines that they're using to wrap up the campaign of eradication. All that said, I'm not that worried given the preliminary results on these vaccines that somehow we're going to be putting the healthcare workforce at greater risk long term. It may be unduly optimistic, but given the mess they're in now and the real risk they face now, I even think these reports of people having reactions when they get a shot, I think there's been 5 or 6 reports of that out of maybe, I don't know, 100,000 vaccinations or something like that,
Mhm.
bigger. Every minute, like 3 people die. So it's like, I don't know. Relative risk wise, I'm not freaking out yet about vaccinate as the advice.
Brenda, do you want to get in there?
Yeah, no, I think it's an important comment, right? We need to be thoughtful, and neither Art nor I are epidemiologists or, vaccine scientists, so we don't know. And I think it's important to pay attention to the data, and there is some scariness around these, very important individuals and vulnerable people going first. But I think we can be hopeful that the data is good enough as it is, and if there's any significant change, that we're going to do everything in our power to change course. But right now, I agree. If someone came to me and said, you need to vaccinate right now because you're a very important person, and if you do it, 100,000 other people will do it, that will never happen. But if it did, yeah, I would do it right here on camera. So I just second Art, but also respect the concern.
And obviously there is a lot of public concern about this vaccine, being developed quickly, without, years of data. Anything that you can say, and then the historical problems with the African American community. What do you say to people who raise these concerns, or what can people say to others?
I hear you, and respect the position, and no matter what you choose to do, continue to be a responsible citizen, and socially distance. Wear your mask if you're not going to vaccinate. But I'll stop there. Art?
Well, look, I mean, some of it is, are you listening to anti-vaccine misinformation about general vaccine risks? And I think that's often erroneous and overblown. So I would go to more reliable sources than some of the traditional anti-vaccine campaigners. Second, I think you're going to have a test, which we rarely see, which is, do the death rates go down, and what's happening to people who got vaccinated? So if you're hesitant, you may want to wait a little, but I think you're going to see that people get protection. And given the risk factors that are out there, that's pretty important to pay attention to. The last thing I might say is, if you're worried because you think maybe these vaccines weren't fully tested, I don't think that's true. I think they were fully tested. I don't think there were shortcuts or political pressure to bend the data, so to speak, to get them early approval.
And so there's a critical difference between anti-vax and vaccine hesitance, right? To be unsure versus relying on faulty data. And so I think the former, having the wrong data and spreading misinformation, that's ethically problematic. Yes, the data so far is good. I think the only issue is we just haven't had enough time elapsed to be completely certain, but there's enough there that we should, do our duty and participate.
Art, you mentioned reliable sources. Do you have, for people who don't trust the government, for instance, or the mainstream media, do you have suggestions for where they could go for information?
Still, I think the International Infectious Disease Society of America, the American Association of Pediatrics, there's a number of vaccine vetted sites by the medical groups that I think are pretty trustworthy. I don't think the pediatricians have a reason to lie about vaccines. They don't make enough money from them to sort of be compromised in any way, I don't think.
Right. And somebody else asks about the independence of the regulatory bodies like the FDA in the US, the MHRA in the UK, and the EU equivalent. Do you think that those have yielded to political pressure or the pressure to just do something about this vaccine?
Well, it does seem to me that the White House, right before the FDA was going to recommend vaccines, President Trump jumped in and said, you better do that, to Hahn, the FDA commissioner. That seemed to me to be ludicrous because they were going to approve them within the next 4 hours anyway. That was an attempt to get credit that was Trump saying, I spent all this research money and I told you you'd get vaccines. And there's some truth in that, although I think he overspent on vaccines and underspent on testing and masking and trying to do behavior change and also even antibody and other therapies. But so I thought that was an inappropriate intervention. Earlier, he had tried to wangle the CDC and other outfits to hustle it up and so forth. And I think the FDA appropriately fought back. Groups like the Data Safety and Monitoring Board of Warp Speed or Pfizer's Data Safety and Monitoring Board, I don't think they were subject to much in the way of political influence. So I think they're pretty independent. So I'd say overall, despite efforts to manipulate them, I don't think they really yielded.
Can you comment on the liability protection? What happens if somebody is injured by one of these vaccines, and who's covered, and what are the ethics there? Brendan?
So liability protection for vaccines, I do think that the manufacturers, it really depends on the facts, right? But I do think that there's some amount of risk that the manufacturers are not going to be able to escape if something really horrendous happened. But for things like these allergic reactions, right? It would be a hard case to make that the company should be held liable, or that the government should be held liable in those cases. This is, does it classify as an inherently risky activity to get vaccinated? This, in some ways, yes. But ultimately, the safety data suggests that this is a safe thing to do. So I'll stop there. Art, do you have more?
I just believe that AZAR and HHS did indemnify or prevent lawsuits for, I think, 3 years against the manufacturers under the emergency use thing. So I think they have some liability protection that way, unless there's gross misconduct or something.
Right. Yeah. Gross negligence.
Yeah. The Vaccine Compensation Fund exists as an insurance scheme for other vaccines, and I'm assuming licensed vaccines would get under that once they get approved for liability. But it's hard to sue a company generally in the US for vaccine harms. You go to the special vaccine court and it gets mediated more than it does a matter of lawsuits, which makes some critics say, there must be covering up something if they won't let you just haul it into court. But it was actually done as a way to keep vaccine manufacturers in the space. Otherwise, they're afraid there'd be so many lawsuits, frivolous and whatever, that they'd give it up.
Right.
Concern among one of the questioners, won't clinical trials simply shift to poorer countries where access to active treatment is more limited, and what the concerns are around that?
Yes, I think they will. I don't think it'll work though, because the Chinese are in there trying to push their vaccine. And when there is a lot of vaccines, say Johnson & Johnson, their vaccine, single shot, just requires not heavy duty refrigeration. I've seen numbers like they think they can make 2 billion by the end of the year, 2021 end of the year. I think we're going to see a lot of places in the world vaccinated. So it may not be so easy to run those trials anywhere. There's 4 billion people in the world is possible. That's only 2 billion, but I don't know.
Yeah, the energy behind the trials is going to die as long as people are not dying.
Right.
Hey, I have one, if I haven't been provocative here, let me offer one irritating comment by me. We normally think we got to help poor countries because they can't afford vaccines, and that's the old model for measles or whatever diseases that are rattling around. COVID attacks older people. COVID tends to be a high-risk thing for old people. If you look at the map of where COVID is, there's big swaths of poor countries that don't have big time COVID problems. And I think it's because they have an average age of 18, 19, and 20. They're very young. And so, yes, we do need to worry about the rest of the world, but it's a little bit selective, if you will. It just doesn't correlate with poverty for COVID. It also correlates with age, demographics a little bit.
One addendum there. In the poorer countries, why is the average age lower? Well, people aren't surviving into their old age, right? So clearly we need to care about those countries and be concerned about the reasons that their population isn't older per se, while also attending to the needs of those who are actually infected by COVID. It doesn't mean that the disease burden isn't significant, because even if they have less people infected in poorer countries, they have less adequate resources to manage those infections.
Somebody's talking about the Fauci effect. What can we do to rebuild trust in science and medicine? Is this an opportunity in some ways to do that?
There is a Fauci effect. I know that medical school applications have gone up. I think they went up 18% or something. So that's a weird Fauci effect. I think more people wanting to get in there and help. I don't know about nursing. Maybe that's gone up too. I just don't know. Or dentistry. But I think that under Biden and the administration that's coming in more committed to science, more committed to listening to scientists, maybe I'm optimistic, but I think there'll be a flip with more prestige and trust returning pretty quickly to science. I think politically, Trump was not enamored of experts and scientists. He didn't like experts generally. Again, that was something he ran on, and it appealed to many Americans, but that's not Biden.
I would say in terms of trust in medicine, we have a problem, which I mentioned, which is that the pandemic is grossly disproportionately affecting people of color. And if we don't do something about that and ensure that the disparate access to healthcare is rectified, and that implicit bias is not creeping into resource allocation decisions that further exacerbates these inequities, then I don't think we're going to improve trust in medicine. In fact, it might get worse unless we can level out sort of the impact across demographics.
And we're getting short on time here, so I'll try to get through a few more questions. But what about incarcerated people? I think some states are prioritizing them, some states are deprioritizing them. We know they've been hit quite hard by this pandemic. Where should they fall, do you think, in the distribution?
Oh, you're muted, Art. I'm going to take advantage to go first then, since you blew it. Yeah, I think they absolutely should fall first. They're vulnerable population. They're incredibly close quarters. The incarceration system is one of the largest employers in the United States, regrettably, in my opinion. And that means that there are a lot of people who are either working there, going home to their families, or people who literally have nowhere to go. And the ways that it is being handled within the system are incredibly inadequate. And so I think they should be among the absolute first in terms of population health and in terms of rights. And the incarcerated population is actually the only population in the United States that has a guaranteed right to healthcare, which is obviously violated all the time. So this might be an opportunity to rectify that.
Yeah, I just had a student look this up for me as it happens. So there are 9 states that explicitly mention phase 1 high priority for prisoners. There are about 14 states that explicitly mention high priority for correctional facility staff, not prisoners, but staff, although there's some overlap between the prisoners and the prison staff, but not 100%, obviously. In some other states, there's an indication that they can only come later in the phase 1 listings. You know, we have 1A, 1B, 1C. So I'd say they're getting some attention, but as Brendan said, uneven. So Karen, I have to apologize because I've got to run off to another
Right. I was just going to
Okay.
say we're sadly out of time, although we have plenty more questions. Thank you both so much. And I want to turn it back over to Dr. Dubrovner for a quick close, and we will try to figure out where I'll post where we can view where you can view the recordings once this is over.
Thank you. Thanks for hosting.
Thanks so much, Art. Oops. Dr. Dubrovner, I think you might be muted.
I see. Okay. If you enjoy this panel as much as I did, I hope this will motivate you to make a donation to GBI to support our educational programs, including our summer school online programs. If you want to make a donation, contact globalbioethics.org/donation, and please do so. Again, I thank you all for attending this panel. Thank you very much, Karen. You did a great job. And let me say goodbye to our audience. And thank you, everybody, for joining us.